Bismillah ar-Rahman ar-Rahim. Alhamdulillah, wassalatu wassalamu ala Rasulullah. My name is Dr. Asiri. I'm a consultant clinical oncologist at King Fahad Medical City. I'm glad to present to you a lecture prepared by Dr. Sajid Durrani, my colleague in King Fahad Medical City. And we're going to talk about side effect of chemotherapy and radiation therapy. Our agenda today, we're going to have a general introduction about chemotherapy and radiation, chemotherapy development, classes and routes of chemotherapy, mechanism of action, type and goal of chemotherapy, precautions, side effect, and a home message after the lecture. Learning objectives of this lecture. By the end of the lecture, you will be able to describe phases of clinical trials, phases of cell cycle, development of cancer medication, define the aim of cancer treatment, whether it is curative, palliative, or neoadjuvant, combined or single, and you will have an idea about toxicity of the chemotherapeutic agents. Chemotherapy is medicine used to treat cancer, and why it is called chemotherapy? Because it's made of chemical agent. It's not natural as medicine before 100 years, mainly from organic or from plant. It's not chemical. But at the beginning of the 19th century, the scientists start to use some chemical stuff to treat diseases. And but nowadays the chemotherapy is a description for the medicine used to treat cancer, and there is more than 100 different types of chemotherapeutic agents. The physician who is dealing with chemotherapy are usually medical oncologists and hematologists. At the same time, some other specialties they're using chemotherapy like rheumatology, endocrinology, and gynecologists for certain type of diseases. The chemotherapeutic agents usually very specific to certain diseases and certain sites, and they carry high toxicities. That's why it is important to know about these chemotherapeutic agents. The chemotherapeutic agents used in cancer care are the ones who are interfering with cell division. Cancer cells are cells divided in a way that not controlled, and chemotherapeutic agent aim is to inhibit the growth and division of these cells. And by inhibiting the growth and multiplication of cells, you will get the result of cell death, which is a target in cancer, and it is something that you try to avoid in normal tissue. And chemotherapeutic agents work in different stages of cell cycles, different phases of it, whether in zero phase or J1, J2, and S phases, and we'll come across this later on in this lecture. There are non-selective action or from chemotherapeutic agent, and this is a problem because as the chemotherapeutic agent kill cancer cells, at the same time it affects the normal cells and manifest as side effect that patients suffer from. Side effect is like alopecia or leukopenia, nausea and vomiting, and others, which we will come across later on. This cartoon shows historical background of how the chemotherapeutic agent produced. At 1908, a discovery of drug made of chemicals by Paul Ehrlich, who is Paul Ehrlich is the father of chemotherapy, and he described chemotherapy in animal model. And the chemotherapy at that time not used to treat cancer, but used to treat other diseases. Alexander Fleming in 1928 he discovered penicillin, which is a milestone in history of medicine. And from that time, from each decade, there is a new discovery of chemotherapeutic agent, which is used to treat different diseases. After the World War II, the start of chemotherapy to treat cancer, and the first chemotherapy was produced at 1950s when the world they noticed that some of the chemical weapons cause leukopenia for the soldier, and from there they thought that because it causes lowering of WBCs and blood cells, it may be useful in treating lymphoma and leukemia. And the start of the chemotherapy at that time, after they used some chemical weapons and being manufactured and produced and tailored to become active chemotherapeutic agent to treat cancer. And from that time, at each 5 years, there is a new chemotherapeutic agent to treat cancer. In 1958, methotrexate discovered, in 1957, 5-fluorouracil, and so on. And in the 60s, phencyl alkaloids discovered. In the 90s, taxanes discovered. And almost every year, there is new chemotherapeutic agent discovered to treat cancer patients. How this drug developed at three phases. Any chemical drugs or chemotherapeutic agents or any medicine must be tested in the lab at different levels. Phase 1 trial, phase 2 trials, and phase 3 trials. Phase 1 trial is the trial where they try to find the optimum dose for which is safe in human being. So they will just define the toxic dose, and from there they will identify the right dosage to be used safely in human being. And at the same time, they will have an idea about scheduling and early side effect. And once they move from phase 1 and they knew the toxic dose of the medicine, they will move to phase 2 clinical trial, which is mainly to see the response of different type of cancer. Usually they do this phase at lab level, and they use cell lines from leukemia, from lung cancer, from breast cancer, and from head and neck cancer, and from lymphoma. And they will see whether this new drug is effective in these common diseases. So they will test it at different diseases, and they will know from there in which disease this medicine is useful. And once they finish that one and they knew which cancer respond to the treatment, they move to phase 3 clinical trial, where they compare the new medicine to the standard medicine. So they compare X medicine, which is not yet tested in patients, and they compare it to the standard care, which is known before. We'll move from this to the phases of the cell cycle. As we mentioned before, most of the chemotherapeutic agents work on cell cycle and at different phases of the cell cycle. In the cell cycle, there is 5 phases. Start with phase 0, or called G0, and this phase is the resting cells. This is cells which is quit the cycle, and they rest aside, not getting to the cycle. So these cells are usually dangerous because it's not get affected by chemotherapeutic agent because it's not cycling. And those cells sometimes remain dormant for years. Most of these cells are not affected by chemotherapeutic agent. Then we go to G1 phase, and this is where the cell start making more protein and growing larger, and they respond to the cell movement, the cell cycle. And this phase lasts usually from 18 to 30 hours. So within a day plus 6 hours, this phase will complete. Then we move to the S phase, which is DNA synthesis. S letter came from synthesis. This is the phase where the DNA synthesized, where the chromosome, which containing the code, became copied and new protein synthesized, and that lasts from 18 to 20 hours. Once the DNA copied and protein synthesized, the cells will move to the G2 phase, and this is where the cells check the new DNA produced. So there is checking the cell by Almighty Allah subhanahu wa ta'ala, get the DNA checked whether it is proper DNA, which is copied correctly, it is same as the pair, before it moves to a new phase, which is the M phase mitosis, where the cell divided to two and became a new cell. So during this cycle, a new cell born and a new cell produced. This is the cartoon of what we said before. You can see on this cartoon the G phase, which is outside the circle. And then you have the GAP1 and S phase, where DNA synthesis, G2 with cell prepared to divide, and M phase, where the mitosis come and new cells produce. There's another cartoon for the same, where you see the cell started with one and eventually became two. And this is what happened exactly in cancer, produce in a way is not controlled, and different chemotherapeutic agents work at different phases of the cell cycle. There is different family of the chemotherapeutic agents, and there's broad spectrum of different chemotherapeutic agents, which we say before, more than 100, and each one of them belongs to a group of chemotherapeutic drugs. We have an example like cisplatin, where it works in DNA, it causes DNA damage, and it is non-classical alkylating agent, 5-fluorouracil, block enzymes that eventually important for RNA and DNA synthesis. Docetaxel inhibit microtubules formation at M phase of the cell cycle. And nowadays we have more specific kind of medication called targeted therapy, where it works on a specific target on the cell membrane or cell nucleus. Example of it, rotinib and cetuximab, where they are antibodies bind to epidermal growth factor or epidermal growth factor receptor tyrosine kinase. Tyrosine kinase. The current status and future trend of chemotherapy. Chemotherapy, since the discovery before 70 years, was started to use as palliative treatment, and nowadays became curative treatment for a number of diseases that we're going to talk about. And we have, thanks Allah, a lot of success in cancer therapy, where chemotherapy is used to cure cancer. An example of that is acute leukemias, chronic leukemias, and Ewing sarcoma, choriocarcinoma, testicular cancer. All these diseases is treated by chemotherapy alone, without surgery, without radiation, and cure is the case in majority of the patient. And chemotherapy is used as an addition to other treatment like surgery or radiation or hormone therapy to extend patient survival and reduce the chance of local recurrence. An example for that, the common example is breast cancer and colon cancer and lung cancers. Chemotherapy usually is a part of multimodality treatment. In cancer, patients get treated by surgery, by radiation, by chemotherapy, by hormonal, by immunotherapy. So chemotherapy is one part of the multidisciplinary treatment. And example for that in head and neck cancer, where you need to have lymph node dissection and resection of the tumor, and radiation therapy. In addition to chemotherapy, sometimes you have to try immunotherapy to treat this kind of diseases. And thanks Allah, the toxicity of chemotherapy became more manageable. In the past, cisplatin, when it was discovered in the 60s, was held for more than a decade because there is no effective medicine for nausea and vomiting. And once the effective treatment for nausea and vomiting discovered, they go back and use cisplatin as a very useful and very successful chemotherapeutic agent. So we have nowadays better supportive therapy for nausea and for vomiting, for myelosuppression as G-CSF or interleukin, for other inflammatory response. Nowadays also there is a trend to use chemotherapy in non-malignancies like in severe rheumatoid arthritis or severe SLE. Sometimes it's used in multiple sclerosis and Crohn's disease. Also, it is commonly used in organ transplantation like methotrexate and azacitidine. So it is not only for cancer, but can be used in different benign diseases. Also, recently, in the last 15 years, there is new targeted molecules which is working in specific target on the cell membrane, specific target in nuclear membrane, and those medicine usually designed to attack certain area on the cells. And the beauty of this kind of treatment, it is highly specific, and its side effect is far below and far better than the chemotherapeutic agent that we know before it cause severe side effect. The targeted therapy usually cause minor side effect like skin reaction and minor allergy, but it attack a certain part of cells and patient get huge benefit. And the best example of that is Glyphic, which is used in chronic leukemia, and it's improved survival dramatically with minimum side effect. These monoclonal antibodies usually work in combination with chemotherapy, and some of it can work alone, as we said, in chronic leukemias. The route of chemotherapy, almost all the routes that used to deliver medicine from outside to the body is used in chemotherapy. The very common route is intravenous access, but is also available in oral and intraarterial, intracavitary, intraperitoneal, intrapleural, isolated organ perfusion, and even intrapericardial and intraarterial, in addition to intravesical, intrathecal. So all these access is a common access for chemotherapy. But the most common access is the intravenous, followed by oral. The intravenous chemotherapy is most of the chemotherapeutic agent known is given intravenous, like cyclophosphamide, 5-FU, methotrexate, cytarabine, taxanes, vincacolloids. All of these is given intravenous. And some of the chemotherapeutic agent can be given as a tablet. And the common example for that is capecitabine, which is commonly used in colon cancer. And also etoposide, also available as a tablet. Some of it can be given intrathecal, like methotrexate and cytarabine. And some of them is contraindicated to be given intrathecal, like vincacolloid. So if it's given intrathecal, usually patient will die within a few days. So this is not allowed to be given intrathecals. This is where the different family of chemotherapeutic agents work, and then at the DNA, at the cell cycle. Some of it work at DNA synthesis, like antimetabolized, 5-FU and methotrexate. Some of them is working as a alkylating agent, like cyclophosphamide and ifosfamide. Some of them is working at mitosis and in phase, like taxanes, where they cause spindle poisons. and some of them intercalating agents where it work in DNA duplication and DNA transcription. And the beauty of this, that when the chemotherapeutic agent work a different cell cycle, will attack cells at any stage of the cell cycle. This will give you a benefit, and the chance of cure will be more. And this is when they design a protocol for chemotherapy, for example, the ABVD for Hodgkin lymphoma, or CHOP for non-Hodgkin, or complex chemotherapeutic protocol in leukemia and Wilms tumor. They try to choose one drug from each group. So we'll attack the cells at different level of the cell cycle. Alkylating agent, this is very common group, and probably this is the first group discovered. And alkylating agent is positive charge forms of covalent linkage with negative charge DNA base combined with the DNA at more than one site, and it causes cross-link of the DNA. Once there is cross-link with the DNA, it cannot duplicate and cannot copy itself. Example of it is busulfan, carboplatinum, chlorambucil, carmastine, and cyclophosphamide and ifosfamide. Other group, which is very common group, anti-neoplastic antibiotics. They are similar to antibiotics, and it work in similar way like antibiotics. It work on telomerase 2 inhibitor, which is an enzyme at the cell, and cause DNA cleavage. The most common type of the antibiotic chemotherapy is dactinomycin, bleomycin, dauropysin, and doxorubicin, and those medications very commonly used in lymphoma and in leukemia. Antimetabolites, they are working at certain protein on the cells, and example of it, antifolate like methotrexate, bimethotrexate, fluoropyrimidine like 5-FU, capecitabine and cetarabine, gemcitabine and azithromycin, thioprines and 6-mercaptopurine, and purine analog, which is similar to the purine in the cells, but it's not purine, so the cells think it is purine and it is not, so the cells will not move and synthesize the DNA. And the example for purine analog is the fludarabine and cladribine, which is commonly used in leukemias. As we mentioned before, the antibiotic chemotherapeutic agent work in certain enzymes, and it prevent DNA from replication. Mitotic inhibitor, the example of it is etoposide. They are topoisomerase 2 inhibitor, which is another enzymes within the cells, and some of it also work in topoisomerase 1 inhibitor, like topotecan and irinotecan, fenblastin and vincristine. Those kind of medication are produced from plant, and they are very active in leukemia and CNS tumor. They cause cell division by damaging the microtubules, which are essential for replication, and cause metaphase arrest and spindle poisons. Other miscellaneous agents like docetaxel, hydroxyurea, asparaginase, paclitaxel, and they are different type of chemotherapeutic agent working mainly on M phase of the cell cycle, and they are very active in breast cancer and in ovarian cancer. Different kind of chemotherapy has certain toxicity. Some of it is neurological, some of it is nephrotoxic, some of it is hepatotoxic. And the common neurotoxic medication, as we mentioned before, the phenylalkaloids, where they are highly neurotoxic, and when they give an intrathecal, they usually kill the patient. So it is usually given intravenous and usually came in a small bag. And there is a lot of labels to just give this medicine intravenous, because if it is given in either route, it causes major damage. Methotrexate, for example, accumulates in body fluid, so the dose of it must be adjusted if the patient has ascites or pleural effusion. Taxanes like docetaxel and paclitaxel cause hypersensitivity reaction, and usually patient warned about this before, and pre-medication use with a steroid before giving this kind of medication, usually given with antihistamine and steroid and given slowly, so patient will not have a major allergic reaction. Some of the chemotherapeutic agents are physicant, so they cause a major skin reaction, sometimes tissue necrosis, and we call it physicant. And the example of that is phencycloid, anthracycline, and mitomycin C. If they get out of the cannula and there is any leak around the cannula, it causes skin necrosis, and sometimes all the level of the skin to the bone will go necrotic. So you have to be sure the access, the intravenous access is good and patent, so you prevent the leakage and you prevent extravasation and tissue necrosis. Chemotherapeutic agent can be used as primary treatment, curative treatment, or adjuvant treatment, neoadjuvant and concurrent, and can be used as palliative, and we'll come to explain each one separately. We have primary chemotherapy when the chemotherapy is the main modality for treatment, when it is used to cure cancer. So after the biopsy, after confirmation of the disease, you start the patient on chemotherapy alone, and that's mainly in hematological malignancy, like acute leukemias in adult and pediatric, where the chemotherapy is the cornerstone of the treatment, and the cure rate is extremely high. And we have now in acute leukemia in pediatric, the cure rate is more than 90%. Hodgkin lymphoma, the cure rate is more than 80%. Non-Hodgkin lymphoma, the cure rate is more than 70%. And these diseases treated mainly by chemotherapy. The chemotherapy either in this group either be given a single agent, but this is unusual if we use it for a cure, and most of the time it is used as combined, where they combined more than 4 medication in addition to steroid and others to cure cancer. Chemotherapy can be used as adjuvant. That adjuvant is addition to another type of surgery, other type of treatment. For example, adjuvant to surgery, adjuvant to radiation. And the best example for that is the breast cancer, where the patient could have mastectomy or lumpectomy, followed by chemotherapy and radiation. If chemotherapy at this setup, when it is after the surgery, it's called adjuvant treatment. And the target here is to improve survival, to reduce local recurrence. Also can be used in rectal cancer, where the surgery will deal with the gross disease, and chemotherapy and radiation will deal with microscopic disease, and chemotherapy will deal with potential disease in the body, which when we think that the cells spread out of the primary site. Neoadjuvant chemotherapy, sometimes the tumor is large and the surgery is not possible, or it may carry some side effect like blood loss, like major loss of function. And the best example of that also is breast cancer. So it is common practice nowadays to use chemotherapy before surgery when the breast cancer size is more than 3 centimeters, or if there is any lymph node metastasis. Common example also is the rectal cancer, where chemotherapy and radiation given before surgery to improve the local control and make the surgery easy. Another example in sarcoma, which is near joints. So when the surgeon like to preserve the function, to preserve the joint, so it can give the chemotherapy or radiation upfront before surgery to make the surgery a small size and easier, less blood loss, less infection, small scar. And this type of treatment was given before surgery called neoadjuvant chemotherapy. Neoadjuvant chemotherapy. Sometimes chemotherapy can be given concurrent with radiation. This is the most common addition when the chemotherapy and radiation given together. And the example for that is rectal cancer, where the capecitabine given with radiation before surgery. Another common example is in head and neck cancer, where you give platinum-based chemotherapy or taxane-based chemotherapy in addition to the radiation to the head and neck. Another example for that is the brain tumor, when you give radiation to glioblastoma multiforme in addition to temozolomide chemotherapy, which used in brain. Also, it can be given concurrent in lung cancer and also in bladder cancer. And this type of combination called concurrent chemotherapy or concurrent chemoradiation. Goals of chemotherapy, just to repeat again, just to cure. And the example for that is Wilms tumor, acute lymphocytic leukemia, testicular cancer, Burkitt lymphoma, and non-Hodgkin lymphoma. In some of these diseases also radiation can be used. For example, prophylactic for CNS disease or to improve and optimize the chance of cure in Hodgkin and non-Hodgkin lymphoma, and also can be used in Wilms tumor. And this group of patients, usually the aim of treatment is cure. To control, where prolonged remission, reduce local relapse, the example of that, rectal cancer, breast cancer, as we mentioned before, or sometimes to palliate symptom if the disease is beyond control and metastasize to a different organ. So you like to improve the quality of life of the patient, improve the oxygenation, improve the appetite, decrease the pain, and here was chemotherapy used to relieve this kind of symptom. And the best example of that is pancreatic cancer, where the patient comes probably with a resectable disease and has either obstruction or back pain, and chemotherapy may improve the patient symptom. When you plan patients for chemotherapy, you have to decide that based on different factors. The most important of it is the type of cancer. So whether this cancer is responsive to the chemotherapy. Some of the cancer is not responsive. Example for that is melanoma and renal cell carcinoma, where they are not that responsive to chemotherapy. Second to that is the patient performance status. You didn't give chemotherapy to a patient where he's very sick or intubated or in ICU or advanced age. So patient should have reserve in his liver function, reserve in renal function, cardiac function to tolerate the toxic effect of chemotherapy. You have to discuss this with the patient family. You have to look to his nutrition status, to his social background, to arrange for him to come to the hospital because most of the chemotherapy is very toxic. So you should have, the patient should have proper support in the local area where he lives. And it usually, the doses depend on the patient body surface, which is calculated by a certain equation. Depends on the patient weight and height. In addition to if the patient had any chemotherapy before, if he had major side effect of the chemotherapy, sometimes the oncologist will decide to reduce the dose if the patient had previous treatment or he had reaction of a previous dose. So with each cycle, the oncologist will decide whether to go with the full dose, 70% of the dose, 50% of the dose, and so on. You will think about some common side effect of chemotherapy, because we mentioned at the beginning of the lecture that the chemotherapy I always say it's blind. It doesn't recognize what is the cancer cell, what's not cancer. So what's given to the patient, it affects other organs, especially the cycling cells. And the cycling cells in the body are, the common cycling cells is the blood cells like RBCs, WBCs, platelet, and so on. Also the cycling cells like mucous membrane cells. So hair, because it is always produced, mucous membrane, you have always changed almost every week. So these cells usually has severe side effects from chemotherapy and came as skin ulcer, sometimes like mucositis in the mucous membrane, in the eye, on the private area, in alimentary tract, and sometimes patient will come complaining of diarrhea, vomiting, nausea, and so on. So in hematological group, it depends on, you will see it depends on the life cycle of cells. So platelet age usually from 7 to 10 days. So you expect to see thrombocytopenia within 7 days of the chemotherapy. Red blood cells, usually the life cycle of it is 120 days, so you didn't see it commonly with the chemotherapy because there is a proper long life cycle for red blood cells. But the WBCs and as lymphocytes, neutrophils, their lifespan is very short, from 6 to 12 hours, and you expect to see them within 2 to 3 days of the start of chemotherapy. And these patients need to be noticed because the patient doesn't have neutrophils, so he or she would not be able to fight infection, and they are prone to sepsis. These patients usually present to the hospital with what we call febrile neutropenia. Febrile neutropenia because they will have fever, they will get infection, but they don't have neutrophil to fight this infection. They need proper support with IV antibiotics and sometimes admission to the hospital to support it properly. In cancer, there is some resistance of, as we mentioned before, that chemotherapeutic agents are very effective, very toxic, so it kills cells, but the problem that the body sometimes develop resistance to the chemotherapy. Same way as if I like to make it simple, think about it as antibiotics. Some organisms develop resistance to antibiotics. So the same thing, some type of cancer develop resistance to chemotherapy. This is resistant maybe at the beginning of the treatment, where there's certain clones of cancer cells are resistant, and those ones usually the hypoxic cells usually very resistant to the chemotherapy. Maybe the chemotherapy did not reach, or there is some sort of bump problem within the cells, cause these cells to resist the chemotherapy. Some resistance developed during the treatment, so the patient will respond for 2 or 3 months and then become resistant eventually. One of the theory for that the cancer cells develop resistance during the treatment, or you maybe at the beginning the response you see is from the sensitive cells, and at the end of treatment you left with the resistant cells and you didn't get more response to chemotherapy. And there is a modality to offer act this kind of resistance, either by use different type of chemotherapeutic agent, working a different cell cycle, alternate the chemotherapy with each other. So you will try to play with the cancer in a way that the cancer does not understand, and improve the chance of response. And that's why we use the combination chemotherapy to overcome the resistance and to get a high response rate, and to increase the duration of remission. The aim of combination chemotherapy just to improve the safety and activity. Safety by each chemotherapeutic agent has different toxicity. For example, some of the chemotherapeutic agents are toxic for blood cells, some of them is neurological cells, some of them in kidneys, some of the hepatic. So we'll try to spread the side effect away from one organ. You cannot use two drugs, both of them hepatotoxic. So use one drug which is hepatotoxic while the other drug is hematotoxic. So by dividing the toxicity, that will reduce toxicity itself and improve the safety. And the same thing by choose different chemotherapy, you will have different activity at different level of cell cycle. So you improve the activity by applying different drugs will work in different mechanism on the cells, and also different mechanism of resistance. So you're able to overcome this resistance. WHO response scale for chemotherapy. You will hear that a lot, or you read it in the textbook when you talk about complete remission, partial response, or partial remission, or progressive disease. And there is a definition for each terminology. Complete response when there is complete disappearance of disease on imaging. Complete disappearance of disease on imaging. And imaging either CT scan, MR, or PET scan. So if the disease completely disappeared from previous images, you call this complete response. Partial response, if you have, if the size on imaging modality reduced by more than 50% without new lesions. Sometimes you have good response at lymph node, for example, but you get another lesion. The good example for that is breast cancer, where patient could have axillary lymph node metastasis and received chemotherapy. And while she's on chemotherapy, the physician noticed that the axillary lymph node disappeared, but when he ordered CT scan, he found new spot in the lung or new spot on the liver. This is not a partial response. She had excellent response in the axilla, but she developed a new spot. And so this is progressive disease. So partial response is more than 50% response in size without new lesion. Sometimes we call it stable disease, whereas there is no increase in the size, the tumor did not increase and did not decrease, and there is no new lesion. Or we may have progressive disease where the patient have low response and from 25% or low or increase in the size of the tumor, plus development of a new spot or new lesion at different size. And why we use this definition? So if the patient had complete response, most of the oncologists usually like to give 2 more cycles after the complete response, because the imaging modality available will not show the subclinical disease. It will show disease when it is the size of 1 centimeter, but it will not show subclinical disease when the disease is microscopic. So the recommendation to give 2 more cycles after the complete response. If you have partial response, then either to intensify the chemotherapy or to change the modality. If you have stable disease, you may continue the same chemotherapy. If the patient has progressive disease, the usual plan is to stop chemotherapy line and to start a new line if you think the patient will respond to the new line. But it is unusual to continue chemotherapy while the patient have progressive disease. So it is indication for change of management or to use different modality, either new chemotherapy or radiation or surgery. What's the condition where we need to stop chemotherapy? If the patient had infection, so chemotherapy will cause immunosuppression. So if the patient develop a fever or develop infection, you have to stop chemotherapy and you treat the infection to avoid septic shock. If patient had previous chemotherapy given within 10 days to 2 weeks, because the side effect of the previous chemotherapy will affect the new cycle of chemotherapy unless this is planned. Example, in Hodgkin lymphoma, the chemotherapy usually given every 2 weeks, but this is an exception. Most of the chemotherapeutic agent given within 3 weeks. Some chemotherapy given weekly, but the treatment was given weekly, usually with low dose. So it's not absolute contraindication for chemotherapy, unless it is bland. Again, leukopenia and thrombocytopenia, if patient develop either of those, it's better to hold chemotherapy and support the patient to avoid major bleeding or septic shock. If the patient is debilitated, his nutrition is bad, and he's not tolerating the chemotherapy, it's better to postpone it and support the patient either by parenteral nutrition or proper nutrition till he became capable of receiving chemotherapy. Pregnancy is not absolute contraindication for chemotherapy. It can be given. Chemotherapy can be given in the third trimester safely in most of the cases, but it is advised to avoid chemotherapy in the first trimester. And also it's advised to avoid antimetabolite chemotherapy at any stage of pregnancy. Other than that, the chemotherapy can safely given in the third trimester. And nowadays also some institutions they start giving chemotherapy a second trimester. Major surgery within 2 weeks, after surgery, patient will require protein, and he need to, infection is common at this period. Bleeding also is common at this period, so it's better to delay chemotherapy till 1 month of surgery. If the patient is not compliant, if he's living far away, is not ready to come to the hospital, there is no local support, it's not fair to give the patient very toxic medication without support. So if the patient is willing to have chemotherapy, he has to live around a healthcare provider in a way that he gets supported if needed. At the same time, we need some surgical support for patient to tolerate chemotherapy and its toxicity. Chemotherapy usually decided based on the choice of oncologist or hematologist based on the tumor type, patient performance, and renal function, hepatic function, cardiac function, and bone marrow reserve. And if the patient has any concurrent medical problems, and patient should be willing from a psychological point of view to receive chemotherapy. The two major challenges that we oncologists face in cancer care is the severe toxic effect of chemotherapy, which sometimes led to severe side effects. Some of it is death and septic shock and severe allergic shock. And the second major problem is drug resistance and poor response to the chemotherapy. And nowadays, alhamdulillah, most of these toxic effects and drug resistance is overcome, and most of the patients, if they are willing and supported, will deal with these challenges is minor. We talked already about resistance to chemotherapy, and as we mentioned before, either primary resistance from the start of the treatment, and that's very common, melanoma and renal cell carcinoma, and or acquired resistance while the patient on treatment, and probably because of cell adoption to chemotherapy and became familiar with it, and so is not effective. And common example or common similarity for that is antibiotics for infection, where some microorganisms develop resistance to antibiotics, and same thing, the cancer cells may develop resistance to chemotherapeutic agents. Nowadays, there is, as we mentioned before, targeted therapy, where we target certain molecules on either nuclear membrane or cell membrane. And the old example of that is tamoxifen, where it is when you have estrogen receptor available on the nuclear membrane or progesterone receptor available, you give the patient tamoxifen. And nowadays there is also the monoclonal antibodies were affecting certain factor or receptor on the cell membrane, like HER2/neu with trastuzumab or Herceptin, commonly used now in adjuvant therapy for breast cancer. Cetuximab, which work on KRAS gene in colon cancer, and epidermal growth factor receptor in lung cancer. If it is there, you can give the patient erlotinib. So these kind of medicine tailored where the target is there. If the target is not there, so this kind of treatment is not useful. And the other problem with those medications, they are very expensive. So you try to give it to the patient who's going to respond to it, and the target for the cytotoxic medication is available for the cells. Complication of chemotherapy, it is different chemotherapeutic agent work at different site, working at different organs. So you will notice wide spectrum of complication from top to toes. So if you think in a way, you start from the alopecia, conjunctivitis, mucositis, and so on. And each drug has its own spectrum of side effect, which is usually explained to the patient before the treatment and explained clearly before he signed the consent. You can see from alopecia at the top, mucositis, pulmonary fibrosis, cardiac toxicity, sometimes nausea, vomiting, hepatic toxicity, increase the liver enzymes, nephrotoxicity, drug which is affecting the kidneys. Sometimes certain type of chemotherapy cause severe diarrhea or cystitis. Some of it cause hemorrhagic cystitis. Big group of chemotherapy cause sterility, either because of ovulation problem or affecting on testes. Some of it will cause myalgia, neuropathy, which is usually affecting the hands or the lower limb. So it is different kind of toxicity, and that depends on the drug used and the dose and frequency. Some of the toxicity is early toxicity that based on when the medication affecting a short or cycling cells like cells of the skin, cell of mucous membrane, cell of cell skins like hairs. And common example for early toxicity is nausea, vomiting, and alopecia. Nausea, vomiting is a common toxicity for cisplatinum and finca colloids, while alopecia is very common toxicity with almost probably 70% of chemotherapeutic agents cause toxicity. A common example of it is cyclophosphamide, antibiotics, chemotherapy like doxorubicin and others, and etoposide. The early toxicity is not a problem. Usually it's self-limiting. After the chemotherapy is stopped, it will come back. For the alopecia, usually within 2 months of the chemotherapy, they start to grow. Vomiting and stomatitis usually within a week will resolve, and they are not a major problem, and the oncologists do not pay much of attention to it because it is self-limiting and short. The major problem is the late toxicity, which when the chemotherapy cause cardiomyopathy, which sometimes led to heart failure, or lung fibrosis, infertility in male and female, and secondary malignancy, which is in the ratio of 1 to 2 in 1,000 with alkylating agent. Some patients will develop second malignancy, and there is difference of time between the chemotherapy and second malignancy, usually within 20 to 30 years of the exposure to chemotherapeutic agent. And those late side effects usually unavoidable because first you cannot anticipate it, and the symptom will appear very late, sometimes after 10 years of the chemotherapy, but usually it will be taken care when the patient is consulted or in the survivorship program after the completion of treatment. There is a specific side effect like hemorrhagic cystitis, and this is very common with cyclophosphamide and ifosfamide. Because of that, there is agents given before or with chemotherapy called MISNA to prevent this kind of side effect. Neurotoxicity, like sensory neuropathy, it's common with cisplatinum, taxane, fincancolloid, and taxane like docetaxel or paclitaxel, and usually it have a specific distribution, and you call it glove and sock distribution, where they affect the hands and the feet as the gloves and socks. Managing toxicity, first to try to avoid by proper education, proper preparation, proper dose, and a proper choice of chemotherapy. If you're giving a physicant medicine, either you give it through central line or you give it with the peripheral line with excellent flow and fast drip without any leakage. If you get patient with bone marrow suppression, it can be supported by GCSF, and it has to discover the symptom when the patient develop this kind of problem by proper follow-up, proper examination, vital sign with each visit, blood test before the chemotherapy to prevent and avoid this kind of chemotherapy. Sometimes you give antibiotic prophylaxis with GCSF if you anticipate infection and immunosuppression. Myelosuppression is one of the most serious side effects of chemotherapy, usually started within 5 to 7 days, 5 to 10 days of chemotherapy. Usually when the neutrophil drop to the lowest level, and we call it nadir, where this is the lowest reading on the CBC, it lasts sometimes for a long time, weeks to 2 weeks, and the mean is 10 days. So in this time when there is myelosuppression, you have to support the patient with antibiotics, with GCSF, to avoid a major infection, which may end by a disaster like septic shock. So any patient with myelosuppression with fever must be admitted to the hospital and given antibiotics, usually combined antibiotics, like tazocine and gentamicin. Also very important to educate your patient about myelosuppression. So if he develops a fever, he should come to the hospital and get support before disaster happen. Gastrointestinal toxicity, common with antimetabolites, especially with 5-FU. So patients sometimes get stomatitis, diarrhea. So patient will be worried about this, given instruction to have good hydration, to avoid certain spicy food, and to avoid hot drinks and hot food to minimize the mucositis. Anemia could be a side effect of chemotherapy, and it is unusual to have anemia from chemotherapy because the RBCs have life is usually 120 days, so it is long lives, and bone marrow is capable of replacing the RBCs. But at the same time, anemia is multifactorial. It could be related to blood loss, could be related to platelet. When platelet is low and the patient develops some bleeding and he will lose some of his hemoglobin reservoir. Probably it is nutrition. Most of the cancer patients, they will have poor nutrition and they didn't have iron reservoir. So they get anemia. And it is not usually a direct side effect from chemotherapy. What you do with patients who develop anemia, first to find the cause of anemia and to fix it, either by if patient has hemorrhage, so you may need to fix hemorrhage either by intervention, scope, radiation, surgery. If the anemia because of blood loss related to a platelet, so you have to correct the platelet. And if you have to give blood transfusion, usually 1 unit of blood transfusion will improve hemoglobin by 1 gram per deciliter and hematocrit by 3%. Sometimes they use erythropoietin injection to improve hemoglobin level. If you fix the hemoglobin level, the patient will have better quality of life, better oxygen, and he will be able to care for self and improve his tolerance and compliance with chemotherapy. There's specific toxicity like nephrotoxicity. This is major complication, and it is avoidable if you give your patient enough fluid, if you give the medication over long period. And the most common example for nephrotoxicity is cisplatin. Cisplatin is only nephrotoxic, and nowadays is given over long period, 3 to 4 hours, and sometimes given over longer than that to reduce the renal toxicity. In some centers, they do dialysis for the patient to get the nephrotoxicity of cisplatin, because it is very effective medicine and a very effective cytotoxic agent. Also, to avoid this problem, it is important to check your patient for renal function before chemotherapy is given. Glomerular filtration rate must be checked prior to chemotherapy, creatinine clearance, and monitor it during the period of treatment, and also replacement with potassium and magnesium is important supplement to be given with the patient who have nephrotoxic medication like cisplatin or carboplatin. Now, there's a few messages that we like you to know, like age, performance status, and lab tests are important factor to decide about chemotherapy treatment. We have to maintain the balance between activity and safety of chemotherapeutic agent. We have to decide the goal of chemotherapy at the beginning of treatment, and we have to explain that to the patient and family before we start, whether our aim is cure, our aim is adjuvant, our aim is palliation. So there will be some mutual agreement between the patient and his physician before the start of that treatment. Side effects must be explained clearly to the patient and his family to get the right support and to get the right treatment if these side effects develop. A lot of chemotherapy has narrow therapeutic windows. What we mean by that the dose must be adjusted to avoid side effects. So therapeutic windows are small. You can't get a proper effect unless you have some side effect, and that has to be balanced in a good way. Chemotherapy can cure a lot of cancer, and nowadays if you take cancer as all, the cure rate up to 56%, which is an achievement. If you take some kind of cancer, the cure rate is more than 95%, like a certain type of leukemias in pediatric and lymphoma. Adjuvant chemotherapy is used after resection or after surgery. Neoadjuvant chemotherapy is used before surgery, and concurrent chemotherapy when you combine chemotherapy and radiation at the same time. And palliative chemotherapy when you give chemotherapy to palliate certain symptom patient is complaining of. And when we use palliative chemotherapy, we usually use single agent to avoid the complication of multiple chemotherapeutic agents. Thank you very much, and may Allah subhanahu wa ta'ala help you and direct you to the right path and to take care of your patient. Thank you.